What clinical findings confirm a relapse of optic neuritis? This is an important question because you have an optic neuritis, you're going to have to treat it early with corticosteroids. And if it's a relapse, oftentimes that means chronic immunotherapy. The only drawback is sometimes it can be difficult to tell the difference between an attack and a pseudo-relapse. Patients who have prior optic neuritis will often have fluctuating vision. Sometimes they'll have fluctuating pain and headaches, and therefore it can feel like an attack even though it's not a true attack. It's important not to treat every single pseudo-relapse as a true attack because that means increased corticosteroids that has lots of side effects. And two, it might mean chronic immunotherapy where it's not absolutely necessary. And therefore, we need to have objective ways of confirming a true optic neuritis attack. And we can see that on the eye exam and some ancillary testing. With a true attack, oftentimes the pupil doesn't react quite as well. They get a relative afferent pupillar defect where we can shine light on the pupil and it just doesn't constrict as briskly as it did before. Usually with a true attack, there's enhancement or inflammation of the optic nerve on MRI. On visual fields, we'll often see spots of vision that are missing that's in a specific pattern that is compatible with optic neuritis. And using optical coherence tomography, OCT, we can actually measure the thickness of the optic nerve. And usually during an acute optic neuritis attack, there's often some swelling of the optic nerve. And over time, there's often thinning of the nerve that we can detect on OCT. And with these objective measures, we can actually confirm an optic neuritis attack. And again, this is very important because it's going to dictate how we're going to treat it both acutely and chronically. Oftentimes, seeing a neuro-ophthalmologist is very helpful as well.